All right, let's jump straight in. Welcome to this explainer, where today we're unpacking a true high-stakes medical emergency. We are talking about retinal detachment. And honestly, if you take away just one single thing from our time together today, let it be this. When it comes to a detached retina, the clock is ticking loud and clear. Every single second counts. So how exactly does this happen? What are the sudden red flags you absolutely cannot ignore? And what does the grueling race to save a patient's eyesight actually look like? Let's get into it.
Here is our roadmap for today. We'll start with the anatomy of an eye emergency, break down the 3 types of detachment, and highlight those warning signs and red flags. Then we'll look at prevention and early laser treatments, compare surgical solutions, and finally discuss recovery and post-op care.
Section 1. Anatomy of an eye emergency. Let's look at how the eye functions.
So a retinal detachment is exactly what it sounds like. It's the dislocation of the retina where it pulls away or shifts from its normal position at the back of the eye. To really picture this, I want you to imagine the retina as a highly sensitive sheet of wallpaper. It's supposed to be stuck perfectly, firmly, and smoothly to the back wall of your eye. Light enters the front, hits that wallpaper, and boom, it sends visual signals straight to your brain. But what happens when that wallpaper starts to peel off? Well, that peeling is usually caused by vitreous gel. This is the fluid filling the hollow middle portion of your eye, basically there to help maintain its round shape. In a perfect world, it just sits there, minding its own business. But if a tiny hole or tear forms in your retina, whether from a sudden injury or maybe just having high myopia, this vitreous gel suddenly acts like a sneaky intruder. It gathers inside that little hole, gets right behind our retinal wallpaper, and physically forces the retina to pull away and detach. The second that happens, your vision is in serious trouble.
Section 2. 3 types of detachment. Let's explore the 3 distinct pathways.
The first pathway is rigmetagenesis, or RRD for short. This is exactly what we just talked about, a straightforward retinal tear or hole where that gel gets underneath. The second one is tractional, or TRD. This one is both fascinating and honestly terrifying. If a patient has long-term diabetes, they can develop diabetic retinopathy. That causes blood to leak right from the retina, which then mixes with the vitreous gel. As that blood dries up, it forms these tough, shrinking, fibrous bands. Think of these bands like tight ropes that literally grab and yank the retina right off the back of the eye. And finally, we have serous detachment. Now, this one doesn't involve a tear or fibrous pulling. Instead, it's driven by severe inflammation or even eye cancer that causes fluid to build up and physically push the retina away.
Section 3. Warning signs and red flags. What does this actually feel like? Listen, if you suddenly experience any of these 4 major red flags, you are in the danger zone. First up, a sudden decrease in your eyesight. We're talking a massive drop happening rapidly, usually within a single day. Second, the sudden formation of many floaters, not just 1 or 2, but an absolute explosion of spots, lines, or shadows swimming across your vision. Third, sudden flashes of light that literally look like lightning strikes going off inside your eye. And fourth, the sudden development of a dark veil or curtain shadow pulling over your field of vision. If any of these happen, do not wait around. You need an immediate dilated eye exam and a B-scan ultrasound to check if your retina has detached.
There's a quote from the source material that really hits the nail on the head. In case of a detached retina, every hour is important. It's absolutely crucial to understand this urgency. If your retina detaches today and you're on the operating table tomorrow, you might actually regain 100% of your eyesight. But the longer you delay that surgery, the lower your chances become of ever getting your vision back. The eye tissue literally starts to die off and degenerate. It's a race, plain and simple.
Section 4. Prevention and early laser. How to stop the emergency before it starts.
The solution here is surprisingly elegant. If an eye doctor catches a small hole or tear before the retina fully detaches, they can use what's known as a barrage laser. Here's how it works in 3 really straightforward steps. Step 1, the doctor spots the tiny hole. Step 2, they apply a highly precise laser beam right around the edges of the tear. Step 3, the heat from that laser securely seals the tissue. It essentially microscopic spot welds the retinal tear completely shut. And because it's welded shut, that tricky vitreous fluid we talked about earlier can't sneak inside, and the retina stays safely attached. Boom, crisis averted. But hey, a doctor can't laser a hole they don't know is there, right? That is exactly why annual checkups are absolutely critical, especially if you fall into any of these high-risk groups. If you have a high minus number, meaning you are highly myopic or nearsighted, your eyeball is physically longer. That stretches and thins out the retina, making tears way more likely.
Also, if you've ever suffered a traumatic eye injury, you need an annual check for sure. And honestly, just by being over the age of 45 or 50, the vitreous gel in your eye naturally changes its consistency and can randomly pull on the retina. If you're in one of these categories, an annual checkup isn't just optional, it is essential maintenance.
Section 5. Surgical Solutions. Buckling versus PPV.
Now, before we get into the surgeries, let's clear the air and bust some massive misconceptions. There is no medicine, no pill, no specialized yoga, eye exercise, Ayurveda, or herbal remedy that can fix a detached retina. None of it. Let me be totally clear here. Once that structural layer is peeled off, there is absolutely zero non-invasive cure. Surgery is your one and only option to save your sight.
So you've got two main routes a surgeon might take. First, there's scleral buckling. This is an older, classic method done entirely from the outside of the eye. The surgeon actually ties a tiny silicone band, kind of like a little belt, around the outside of your eyeball. They tighten it to push the outer wall, the sclera, inward so it physically touches the detached retina and helps it stick back together. Because it literally squeezes the eye, it can change the eye's shape and leave you with a negative prescription number. Then you have the much more modern and popular approach, pars plana vitrectomy, or PPV. This is all done from the inside. Think of it like a highly advanced laparoscopic surgery, but for your eye. The surgeon inserts 3 incredibly fine needles, so ridiculously small they don't even need stitches. They vacuum out that problematic vitreous gel and replace it with either a gas bubble or silicone oil. That filling expands and pushes the retina backward, right back into its proper place.
Section 6. Recovery and post-op care. Getting ready for the psychological test. As we just touched on, during a PPV surgery, the doctor has to fill the eye with something to support the retina while it heals. They usually choose between a gas bubble and silicone oil, and let me tell you, that choice drastically impacts the patient's life. If they use a gas bubble, it gets absorbed naturally by your body in a few weeks, which is great because you only need the one surgery. But here's the catch, it comes with a strict stomach positioning requirement. If they use silicone oil instead, you can sleep and sit totally normally, but the oil doesn't absorb on its own. That means you are guaranteed a whole second surgery 3 to 6 months later just to get it removed.
Let's be real for a second about that gas bubble requirement, because patients really need to be mentally prepared for this grueling reality. Because gas naturally rises, the only way the bubble actually presses against the back of your eye where the retina sits is if you are face down. This means you must lie completely on your stomach 24 hours a day. To actually survive this, patients often have to rent specialized face-down massage chairs or these unique pillows with breathing holes just to get through the weeks of recovery. You are literally staring at the floor or the mattress all day and all night, and you're only allowed a strict 10-minute break every single hour. It is incredibly physically taxing.
So the big takeaway here is this: recovery is slow and it requires immense patience. A lot of people hear eye surgery and they instantly think of modern cataract surgeries, right? Where you get zapped and you're back at work reading emails in 3 days. Retinal detachment is an entirely different beast. Your eyesight recovers very gradually. A super practical tip, if you or a loved one ever face this, prepare a huge list of audiobooks and podcasts ahead of time. You will not be able to read. You will not be able to watch TV. This demands your absolute patience and strict, total adherence to your doctor's rules.
We started this explainer talking about the race against time. The very second a symptom appears, that clock starts ticking. So I want to leave you with a final, provocative thought to chew on today. When was your last annual eye checkup? Honestly, if you're highly myopic, if you're over 45, or if you've ever had an eye injury, do not wait for the flashes of lightning or that dark curtain to fall over your vision. Take control, stay ahead of the clock, go get those eyes checked, and protect your vision while you can. Thanks for joining me on this explainer, and keep learning.